good afternoon, everybody. So I would like to thank the DADA2 Foundation to let me the opportunity to represent France in this conference. And I will first begin by telling you the two main differences between this conference and the French conferences. The first is that I realized that in the speakers there were 13 women and 13 men, and it's not that often that men can speak in France. So thank you to Chip Chambers and maybe Ivona Aksenchevich. And second, for the lunch in France, do you think that we would have drunk a Pepsi or not? What do you think we would have drunk? Wine. Red wine, yes, that's what we're doing. So I will speak most of my talk on the behalf of the Montpellier. It's the genetic team of our French National Center for Autoinflammatory Disease, which is directed by Isabelle Tuitu, that most of you know. And so this is this paper that I will mainly discuss. And after that, I will keep a few minutes to speak about adult diagnosed with DADA2 and our French experience. So here is how the French Reference Center works. You can easily recognize France in Europe. And we have the main clinical centers that are in Paris region. I work here in the Paris Reference Center, especially with adult patients, and the Montpellier Center we see doing the genetic testing is here nearby the Mediterranean Sea. So here is our center, and you can recognize easily Isabelle Tuitu with a very sexy position. And here is Guillaume Sarabet. He's the doctor who is mainly sequencing DADA2 in this center. So I will not go back to DADA2, but what is important is that when we will describe the French series, is that patients were only recruited, as you can guess, from 2014. And you will also see that the patients represent the French population with many ethnicities. So the two objectives of the paper were, the first one was to describe the clinical features and the genotype of patients referred for genetic diagnosis of DADA2 in our French reference laboratory for DADA deficiency in a context of autoinflammatory symptoms. This is important because I think one of you told that some of his patients didn't have CRP elevation, and in this study, all patients had autoinflammatory symptoms when they were referred to the center, so they had all elevated CRP. And the second objective was to retrospectively identify the symptoms predicting a positive genetic test result and to propose a decision tree to improve DADA2 diagnosis. So all patients screened in this study had a suspicion of autoinflammatory disease, and all of them, the clinicians had filled a common form with the clinical symptoms. So it began in 2014, and the data were stopped in 2017 before the publication this year. All patients signed informed consent. And the main use technique to sequence DADA2 was Sanger for 59 patients. Only 7 had the next generation sequencing, and there was 100% of concordance between the two techniques. To make the statistical analysis, we performed an association between the diagnostic items on the clinical form and confirmation of the disease. It was estimated by odds ratio, and it's 95% confidence interval and a Fisher's exact test. And then the percentage of correctly classified cases was estimated, and the sensitivity specificity of each of these diagnostic elements. So 66 patients were referred to Montpellier Genetic Center with a clinical suspicion of DADA2 between this period. As you can see, 13 were diagnosed with homozygous mutation in DADA2. 3 were heterozygous, and for 50, there was no mutation. So after, when I will speak about comparison between groups, I will always compare the 13 with confirmed DADA2 and the 50 without mutation. Concerning the 13 homozygous mutation DADA2 patients, the mean age at outset was 12 years old, ranging from 1 to 33. The mean age at diagnosis was 20.8 years, ranging from 7 to 39. 8 had compound heterozygous mutations, and 7 displayed new mutations. Some quite interesting thing is the discipline of referring clinicians. The blue are the main clinicians. 50% were pediatricians and about the same were adults. The main adult clinicians were internal medicine specialists. There were also dermatologists, nephrologists, and hematologists. And the main pediatricians were rheumatologic pediatricians, and some of them were neurologists or dermatologists. The patient origin, as I told you before, was reflecting the French population with mainly European Caucasian patients, but some Maghreban patients coming from the north of Africa, and some African and some other rare origin. So the main result, the first result was this one. As you can easily guess, the most frequent association for DADA2 patients compared to patients without DADA2 was fever and neurological or cutaneous involvement. And when we compare the two groups, with or without mutations, DADA2 patients present in significantly more fever and cutaneous involvement, or fever and peripheral inflammation, so CRP elevation, and neurological or cutaneous involvement. And another significant association was fever and neurological involvement, plus or less cutaneous involvement. So our aim is now to speak more to our colleagues from other specialties about DADA2, especially at the intersection of cutaneous, neurological, and inflammatory symptoms, which can be clinical as fever or biological with elevated CRP. And then in this paper, there was a proposition of a decision tree for the genetic diagnosis of DADA2. So the first important thing is the prerequisite, which includes three things. Firstly, signs of inflammation, fever, so clinical sign, or elevated CRP, biological sign, plus sign of vasculitis, either cutaneous or neurologic or both, and a clinical course for adults with more than one recurrence or a chronic course for the evolution. So if the patients had this prerequisite, a Sanger analysis was performed to look for DADA2 mutation. And then when the two biallelic pathogenic variants were found, DADA2 was confirmed. When there was only one pathogenic variant, a qPCR was performed. And when no pathogenic variant were identified, they proposed DADA2 enzyme activity measurement and or medical expert advice through our center and next generation sequencing or exome. So we spoke a lot this day about DADA2 enzyme activity measurements, and we have already discussed together about this. We begin, as you to think it's important, and we send more and more samples to Michael Erfield in Duke, and he performs that very nicely and very, very quickly. So maybe now in 2018, this genetic tree could be implemented with DADA2 enzyme activity, maybe upper in the genetic tree. Now, in the few minutes left, I would like to point your attention to adult patients, because we have in France now 11 patients who were diagnosed at an adult age, and we have 4 more than the one described in this paper. The median age at diagnosis was 22.5 years old. So if there are pediatricians in the room, maybe you think it's quite old, but for us, it's not so old. But it shows that the median diagnostic delay is important. It's 15 years, but of course, all of you know that since the disease was firstly described in 2014, that may explain why the diagnostic delay was important. Another interesting thing on this diapositive is the North Africa origin, and when we look back at the medical file, most of these patients were diagnosed as atypical familial methylmalonic fever or very resistant PAN. So it's now very interesting to point to our colleagues to think about DADA2 deficiency in these patients. 3 had familial cases, most of them originating from North Africa. And the other interesting thing here is the main clinical feature, which was for 5 patients only cutaneous features. I will show you pictures just after. And for some of them, it was psychiatric presentation. Even in 2 brothers, one of them was interned in a psychiatric institution, and his brother had a pan and elevated inflammation and a stroke, so the diagnosis of DADA2 was performed 1 year ago, and then they thought maybe his brother had a problem, so they tested the brother very recently, and they both have DADA2. So this is another story of 2 brothers. One was in a city in France with recurrent ulcers and chronic ulcers that were very hard to cicatrize. And his brother had livedo on the chest and belly. And he also had very chronic ulcer that was almost impossible to treat. So one of the dermatologists had already heard about DADA2 presented with livedo, so he thought about DADA2. He tested this man, who was positive, and then he tested the brother that I showed you before, and it was also positive. So we are now trying to speak more about DADA2 in France to our colleagues, and we tried to show them this little synthesis of the disease so that they can think about it. And we tried to explain to them, to look at the CRP and then look at all the main clinical signs to try to diagnose more DADA2, especially if some cases the parents are consanguineous. Here is the cloud of word. You remember this morning, Chip Chambers showed us about the countries that were connecting to the DADA2 Foundation website. So we also propose to our French colleagues that don't know very well that disease, this cloud of words showing the main features of the disease, and ask them to think about it more frequently. And this is a drawing that was made by one of my patients. He doesn't have DADA2, he has a still disease, but he wanted to show in still disease, but I think it's the same in DADA2, that we have to share data in this disease because it begins usually in the first years of life. It can also touch oldest people, and we have to share together to improve the knowledge and the treatment of that disease. Okay, thank you for your attention.